Welcome to the Do Something Admirable Podcast. My name is Alex. My patients call me Dr. Watson or also Alex. This podcast is both a play on the name of our medical practice, Admire Medical, and the previously unspoken mission of the practice. We help our patients start their next chapter after life-changing events, like amputations, brain and spinal cord injuries, and cancer treatments. This show is for anyone looking to be inspired and then inspire others to do something admirable.
All right, we're back for the next episode. Dr. Alex, today we're going to talk about testosterone replacement and hormone replacement. We're going to touch on the hormone replacement a little bit, but I think we're going to have Angela come in a couple of episodes. But
Great idea.
Tell us about testosterone replacement. There's a ton of that on social media. There's a ton of that in the news. Tell us about it if you don't know what it is.
Yeah, I mean, and even to bring a little anecdote, just this weekend, I had a family member ask me if they have low T and should be tested for low T and that kind of buzzword. So it's definitely worth getting into, as it is, one of the fundamental things to address before a prehab program for somebody who's at risk of these things. So there are a lot of risk factors for lower testosterone, but the most prevalent one being, of course, metabolic disease. There's a negative feedback loop in our bodies that as your insulin resistance gets worse, then your brain releases less of the hormone that tells the rest of your body to make testosterone. And besides just kind of feeling like a man kind of stuff, it has very distinct functions metabolically too. So it becomes a really unfortunate negative feedback, death spiral, however you want to call it, where if you have metabolic disease and then low testosterone, well, that low testosterone makes it harder to build muscle, burn fat, have the energy to be active. It affects sleep quality, all of these things. And of course, once those are run away from you, it's tough to reverse it all.
And we talk about stigmas all the time and myths, right? And that is the thing, is if and again, we've joked about men's health before, about we wait too long sometimes. And it is that low T does feel a little bit embarrassing sometimes, right? I'm sure to some people, but to your point, kind of goes into that whole continuum of care that you always talk about. It is important because it affects your overall body. And like when you read the side effects of low T, there's a tremendous amount that it affects your body.
Oh yeah.
And how does it talks about the continuum of care and how that how that helps?
So for us, and this is where I can tie in a little bit of the estrogen and progesterone replacement for hormone replacement therapy for women. When someone comes to us and they have some 2 months from now planned joint replacement kind of surgery, and either they or the surgeon wants them to get more metabolically healthy, more physically active, that kind of stuff. This is one of the low-hanging fruit pieces where we can quickly address that, and that supercharges all the rest of the stuff we're doing. So if you are able to correct this, I guess that's the positive way of looking at it, because really you're removing a brake from the thing. So you're taking your foot off the brake kind of thing, but really it's allowing the person to respond better to exercise stimuli, to regulate their blood sugar, to, again, have the energy and the mood and the interest in working out daily.
Right. It's not all about libido, which some misconceptions are, right? There's so much more that's built up into your body, it sounds like.
Definitely. And so addressing this early then maximizes the efficacy of the program during a prehab window of time. And the same thing goes for, estrogen replacement too. Estrogen is a necessary hormone in both men and women, actually, that has anabolic properties for building muscle and maintaining bone density. So similarly, addressing that can quickly improve just how someone feels and their willingness to do exercise and stuff like that, but also increases the biological response to those changes you're making. The one difference, though, in the continuum is that you need to have adequate time before the procedure, because in the case of starting estrogen therapy for women, you may have an increased risk of blood clots, and just kind of your blood gets a little stickier, essentially. And so some surgeons and anesthesiologists may not be too thrilled about the idea of starting this thing within a few weeks or even months before surgery. In some cases, they might even want you to wean off of it. That's very case by case, and I won't speak to any specific situation. Less so with testosterone replacement when someone has low testosterone. In those cases, you may have similar increased risk of certain kind of thickness of the blood type symptoms here, but usually there are ways around that to minimize the risk. And again, if you have a long enough window, you can track those changes and really assess any sort of risk and mitigate that pretty effectively, so you get the benefits and can offset any sort of risk.
And let's talk about, because we always look at myths in general, and I think there's a misconception circumstantially, right, or situationally, is if you go on the testosterone replacement, you may have to be on it forever, right? And I think you have some varying opinions on that based on the situation.
Definitely. I mean, there's a number of myths when it comes to testosterone replacement. And I think part of that is the stigma and experience of abusing, or misusing, to not be as negative.
To get your lift on, right?
To get your lift on, yeah. And I mean, you see these YouTube videos of 20-year-old men who are getting bootleg testosterone or stronger anabolic agents like Tren, and totally wrecking their whole feedback system between the part of the brain and the testes to produce testosterone. But there is some truth to it. There's a kernel of truth to a lot of these things. So you do have in that same negative feedback system where increased insulin tells the brain to produce less LH, and so you produce less testosterone. Well, if you're producing testosterone or taking exogenous testosterone, that same feedback system happens that then suppresses your hypothalamus, the pituitary, and so basically your body says, well, I got high enough levels here, why make more, kind of thing. And most hormonal systems in the body work that way. That's a great way to regulate things so you don't get over too high hormone in testosterone, estrogen, thyroid hormones, those kinds of things. But your body can respond appropriately when they get too low. If you're essentially repleting yourself above normal for too long, or even too normal levels, again, the body says, well, we got enough there. Why make more?
And what are normal levels, right? What if those of us on the layman side, is what is a normal level for testosterone? Is there a normal level?
That's a good question. So it depends on a number of factors. The type of assay you're using, so how they're determining these things on your serum tests, will vary it slightly. And a lot of times people are looking at total testosterone, which doesn't have a whole lot of relevance to outcomes. Really, it's the free testosterone. And even then, it's important, but we also focus more on symptoms. So as long as you're not very, very much in the normal area of free testosterone, which again is going to vary based on whatever lab you're using, kind of thing, and have the hallmark symptoms of body hair loss, low libido, difficulty recovering from exercise, sleep impact, mood, those kinds of things, then we typically just kind of treat to the symptoms. A lot of that is subjective, so it's tough to not overshoot the mark sometimes, but that's why you kind of ease into it and find the right system that works and go from there.
And what age do you start to hit? When you start to feel those potentials where you could suspect that it is low testosterone, what age do you really think that starts, in your opinion?
I don't have a lot of experience in repleting this in folks under 40s. Theoretically, there are plenty of reasons to have low testosterone at any age past puberty, but a lot of times in the younger years, it's going to be more of a trauma to the groin kind of thing, and less about this general system producing less testosterone because of metabolic disease and whatever. The common population that we'd see this in is guys in their mid-late 40s, 50s. That's when
everything's broken.
I'm starting to feel it myself. Hence why I shaved my gray beard.
That's right.
That's when you're gonna start considering that, of course, a big factor. And I'm not an endocrinologist. This is just the practice that we do. You can go by those symptoms, go by the age, and then that's enough for me to get a test to just see. Does the lab test correspond close enough to the symptoms they're describing after excluding other known causes for erectile issues and
Right.
poor sleep and all that stuff.
Yeah.
Being, of course, the number one being like depression and things like that. So,
And so let's tie it back to Admire. You guys do a really great job on the education side, and really take the time to help a patient understand. How do you address it? Do you do additional blood tests? How do you figure out the treatment plan to kind of put them on that's the best for them?
yeah. This is where the art and science comes in, of course. And I mean, every single problem we have is mix of art and science between both the medical art and science and
Right.
the logistical with insurance companies and access and stuff like that.
Right. And I think that's important
Yeah.
for everybody to understand, is that's, to me, the magic of Admire a little bit, right? Is that extra moment in the middle to bring those two things together. And so talk
Yeah.
about that a little bit of what you guys really do.
So in a case, just a general case, what we do is see whatever labs they've already gotten, of course. And in a lot of cases, it's going to be a total testosterone and hopefully some of the more broad metabolic assessments too. If we have, fasting sugar that's obviously abnormal, or an A1C that's obviously abnormal, that does a lot of the metabolic side just for us on a quick glance. If they do have a free testosterone that is objectively low and these symptoms go with it, then we discuss ways of either first addressing underlying issues or going straight to the repletion. And this is a very personal kind of decision to make. Some men want to first fine-tune and minimize the medications they got to take, so they fine-tune their lifestyle and try to first address the underlying comorbidities of the metabolic disease and poor sleep and that kind of stuff. Or, like we described earlier, kind of go on the flip side and just treat the testosterone alongside that, knowing that each one's going to get better together, make it a lot easier to treat. But once we decide to treat it, and we have the objective evidence that we can use to get it covered by insurance and everything, there's so many ways of prescribing it, basically. And the most typical is going to be either a cream in a lot of cases, and you see some folks just prefer that because it's simple and there's no injections involved, and you can just do the same time every day. You get out of the shower, you put it on, whatever. But it's not great for everyone either.
Right.
There's a risk of it rubbing off on your partner, or God forbid you have the small kids in the house and you put it on the spot that's exposed because you're wearing shorts for the day, and oh man, now all of a sudden your toddler's growing a beard or something. No, the more common way is twice weekly injection of a certain formulation that makes it nice and easy. You get a nice good kind of double peak of the serum levels, and so that mimics physiology well, doesn't require you to have frequent injections.
Right.
No risk of transferring it to a partner or someone in close contact. But there are unique situations where we use other things too. Women more commonly might be using like one of the pellets. Men, you sometimes have to use a lot of pellets to get what you're looking for, and it's not necessarily comfortable all the time. If you don't mind the frequency of it, there's the intranasal formula, which is kind of cool because then you can use it before certain activities that might depend on testosterone levels to be most effective. So you do your nighttime dose before having sex, or you have your afternoon dose before going to the gym, or morning dose. So you can fine tune it that way, but that's really where you just kind of the fun part, frankly.
Right.
You have to personalize this to the patient and then assess symptoms after adequate follow-up and go from there.
Right. It's not our grandfathers weren't sitting around talking about this stuff, right? This is modern medicine at its best, right?
Didn't come up when I was talking to my grandpa.
That's right. But no, this is great. This is one of those topics that I think we're going to talk a lot about. It's something that's
Certainly.
in your practice, considerably in your practice, and it's something that it's another great example of how you guys take someone down the journey of certainty that they need on a very scary topic that can be long term, that I think you do it in an educational way that I think helps people. So
speaking of long term, I never actually finished the answer to is it permanent? And
that's right. We got away from that.
We started there, then got excited.
Yeah.
There are so the longer you're on it, the more likely you will need some sort of therapy to come off of it. And this gets a bit in the weeds and even a bit beyond my expertise, so I would almost certainly refer to an endocrinologist or urologist for something like this. But there are therapies that you can co-administer. Beta-HCG is the compound that can maintain production at the testicle level, because you'll have atrophy if you're on for a long time, and then it's a little tougher to reboot necessarily. Or there is kind of a protocol that some use to kind of reboot the system as you're weaning off the testosterone. But again, that starts to get a bit more granular, and I don't want to overstate my expertise in the area. I would almost certainly refer out for something like that.
But that goes back as we conclude, right? Is it's not just about coming in for just that thing. It's that whole ball of wax, right? It's the holistic thing, and you really can't look at it as just that one thing, right? You're kind of looking at your overall situation, and we were talking off audio a little bit of, there is a lot you can do, but you have to understand the overall opportunity, the overall challenges, and then something that you guys do really great here at Admire is treating the entire patient, right?
And that's you get better outcomes that way anyway, besides it just being good medicine.
That's right.
And we did want to start including a little bit of a dispelling myth objectively kind of thing here. So we talked about some of the myths of testosterone repletion before, but objectively looking at some of the newer studies, this is a great one that I've been waiting for a while. It's called the Traverse study, right? And so this one hoped to put to bed the myth we discussed earlier about the risk associated with testosterone platelets. Part of the problem was that on TV and everything, you see folks who have been using it for professional wrestling or bodybuilding, whatever it might be.
Mail order.
Yes, exactly. And it's well known that it causes problems in the heart and early cardiac death, those kinds of things. And that was a big worry about, well, if we're going to be treating men for objectively low testosterone, are we causing more harm than risk? And that was the intention of this study, was to say, is this a vanity thing that's not actually optimizing health? And there were many iterations of the study and kind of offshoots and subsets of analyzing the data so that they can get very specific insights to discrete conditions. But the broad one was to say, are we causing more adverse events? And this study was published last year in the New England Journal of Medicine, obviously a prestigious journal for folks who don't sit in the weeds with this stuff. It did, there was nothing's without criticism. And there was a follow-up paper published, kind of editorial, from some cardiologists expressing concern about the structure of the study not being without issues, but taking this at face value, it demonstrated that there were no increased adverse events. You can be on this, and the interpretation of that is going to be kind of how we discussed it. Bring someone from abnormal to normal is the right thing to do, reasonable. It's not it's not going to cause more harm, and then you can explore the benefits that we talked about. Bring them to a super physiologic level. That's not which is not something you would do anyway. Exactly.
Right. I mean, you're not, if someone's coming in and says, "Hey, I want to be in a significant bodybuilding contest," that's not your ideal.
Not
patient.
at all.
Right.
But understanding why the cases we've seen are that way and don't correspond with the study. That's I think how you better understand the safe cases, by understanding why the unsafe ones occurred. And that's that super physiologic dose. That's when you get the risks of blood clots and increased cholesterol production, those kinds of things that end up putting you at higher risk.
And it's also with everything that's out there, there's the opportunity for abuse, and that's why I think the right professional to help you through that journey is why you pick somebody like Admire.
Thank you. And then it's also a scheduled medication, so it's on the Schedule 3, so it has a little bit of federal oversight. So if you're going to get this bootleg, you're breaking federal law here.
Well, not to mention put yourself at risk.
Exactly.
Because you don't know where it's coming from.
Exactly. And the last 2 points with this study that were kind of cool, or actually cool when you understand how to look at it, was 2 of the offshoot studies, looking at the subset of data. One was regarding bone density and one was regarding insulin resistance. So one of the follow-up studies was saying, all right, well, if you're going to fix this testosterone, someone who is objectively low, when you bring them to normal, are you going to improve or prevent the conversion of prediabetes to diabetes? And intuitively, I would say yes, absolutely. That's not what the study actually showed. So when you look at the published data, there are 2 arguments of why that wasn't the case. One, there was a trend towards it, but it wasn't statistically significant. So we say it didn't happen. With confidence, you can't say that it did happen. So you say it's not going to prevent the conversion of prediabetes to diabetes. 2, though, that's in isolation. So when you combine testosterone repletion with an exercise program and dietary changes and sleep optimization and all these things, Are you going to prevent the conversion? Heck yeah, you are.
Right.
You're going to reverse that
Back to that
ANC.
continuum of care conversation.
Exactly.
Yep.
So the big takeaway here is, if you are truly having low T, I used to fight against saying that, but it's just the easier way to bring up a conversation comfortably.
That's right.
It's not irresponsible to ask your doctor, can we do something about this?
Right.
And not only is it not irresponsible, actually, it's the right thing to do for your wellness. If that's something that you are interested in doing, there's no stigma to bringing it up anymore. Right. That's really what I was trying to get at.
Yeah, and no, absolutely, and you're right. Stigma is the one thing we hope to break on a lot of these conversations of, again, especially on the men's health side, is we wait so long for proper care sometimes until something bad happens. So we want to try to reduce some of the stigma for a lot of the stuff we're talking about. And like I said, we're going to talk a whole lot more about this topic as we go down the road. And I know, again, we're going to touch a little bit on the hormone replacement side with Angela and come in. We'll do, we'll have, I think we should probably be both on here, a little back and forth, little tag team. Oh, yeah. Absolutely. So
we've recorded a few of those before.
That's right. That's right. All right. Anything else on the topic?
I think that's it for now, but this is constantly being researched and evolving information because it is so relevant and prevalent.
That's right.
Oh my God. Because so relevant and prevalent. Making up words here.
Yeah, you can say we're unscripted sometimes here.
Yeah, exactly. Right. Yeah, I'll probably edit that out.
That's right. All right.
Right on, man.
We have come to the end, my friends. Thank you.